Niacin's antiatherogenic potential lies in a subtle, yet powerful distinction. It enhances cholesterol efflux at the cellular level, especially within macrophages, without necessarily altering plasma cholesterol concentrations. This diverges significantly from the mechanism of statins, which target liver cholesterol synthesis to reduce circulating LDL levels. Niacin, by contrast, works within immune cells residing in the arterial wall, restoring intracellular cholesterol trafficking and reducing the cellular stress that drives plaque formation and instability. Its ability to promote cholesterol clearance without impacting systemic lipid levels underscores a highly targeted and context-dependent therapeutic effect. At the heart of this action is niacin's influence on the lysosomal cholesterol export system. When macrophages ingest oxidized LDL in the early stages of atherosclerosis, free cholesterol accumulates in lysosomes. This storage site, unlike cytoplasmic lipid droplets, lacks the buffering capacity for large lipid loads. When overwhelmed, it leads to lysosomal dysfunction, inflammation, and eventual cell death. Statins, which reduce the overall availability of cholesterol in the blood, have only an indirect effect on this localized cellular problem. Niacin, however, directly targets the machinery that clears lysosomal cholesterol. By upregulating CD38, niacin enhances the production of NADP, a potent calcium-releasing molecule. NAP triggers calcium efflux from lysosomes through TRPML1 channels. This calcium release activates liver X receptor alpha, LXRA, which then induces the expression of genes responsible for cholesterol export, NPC1 for lysosomal transport, and ABCA1 and ABCG1 for efflux across the plasma membrane. This mechanism allows niacin to drain cholesterol from overloaded lysosomes and shuttle it toward high-density lipoprotein, HDL, particles, even if the overall plasma cholesterol pool remains unchanged. In fact, in several experimental models, niacin-treated subjects displayed reduced foam cell formation and smaller atherosclerotic lesions despite no significant alterations in total plasma LDL or HDL cholesterol. This demonstrates that atheroprotection does not always require lowering circulating cholesterol. It can also be achieved by correcting the dysfunctional intracellular processing of lipids. This distinction becomes especially important in individuals who already have normal lipid profiles but show signs of vascular inflammation, metabolic stress, or early atherosclerosis. In such cases, statins may offer limited additional benefit, while niacin could exert a meaningful effect by enhancing cellular lipid clearance, preventing foam cell transformation, and reducing inflammation at the site of plaque development. Furthermore, this cell-specific action gives niacin a therapeutic edge in avoiding some of the systemic complications seen with broader-acting agents. Unlike synthetic LXR agonists, which can upregulate lipid metabolism genes in the liver and promote steatosis, niacin appears to confine its effects to lipid-stressed macrophages. Its activation of cholesterol trafficking genes like ABCA1 and ABCG1 occurs predominantly in immune cells burdened with lipid, reducing the likelihood of unintended hepatic lipid synthesis. In summary, niacin enhances cholesterol efflux by reactivating intracellular pathways that unload lysosomal cholesterol and facilitate its export to HDL, without significantly altering plasma cholesterol levels. This cell-targeted mechanism reflects a new model of atheroprotection, where the therapeutic focus shifts from the bloodstream to the dysfunctional macrophage itself. Niacin's precision in correcting this imbalance makes it a uniquely valuable agent in the prevention and treatment of atherosclerosis, particularly in cases where systemic lipid levels fail to fully reflect cardiovascular risk.